Hi, this is Peggy O'Connor again, and this is part 4, Caring for the Child with Croup. There are actually 4 different types of croup. The one that we're going to cover is LTB, which is known as laryngotracheobronchitis. The etiology is it's an acute viral illness, and LTB is the most common. It occurs in children between 6 months to 6 years of age, but it does peak around 2 to 3 years of age, and it occurs in boys more than in girls. In pathophysiology, it's usually the para-influenza virus. It occurs in the fall and winter months. However, influenza, RSV, which is known as respiratory syncytial virus, and mycoplasma can also be causes. They have copious secretions and increased respiratory distress. Diagnosis is by history and by clinical signs. Throat culture and visual inspection are contraindicated because that can cause an airway occlusion. Radiographic study may show that there's subglottic narrowing, which is known as the steeple sign, and pulse oximetry shows hypoxemia. The signs and symptoms for croup are usually that the child has had an upper respiratory infection for a couple of days prior to the onset of croup symptoms, and those progress to a cough and a hoarseness. Fever, they might or they might not have a fever. They will have tachypnea, inspiratory stridor, and a seal-like barking cough. Treatment is medical and is done to maintain and improve the respiratory effort with medications and oxygen if the SpO2 is less than 92%. If the child is able to stay at home, there will be prescribed PO corticosteroids, and just recently, no cool mist. They used to recommend that they go into a shower, and the cool mist would help diminish the inflammation in the airway. However, best practice now is that is no longer recommended. If the child is hospitalized, the child will receive racemic epinephrine nebulized, IV corticosteroids, and then switch to PO. Nebulized budesonide, and they might need intensive care unit and intubation if they suffer from laryngospasms. I've posted 2 links to YouTube videos. One is a baby with croup, and the other shows you stridor and retractions, and they're very good videos, and I highly recommend that you view them. I've also placed in here a video from YouTube that shows the difference between bronchiolitis and croup, and seeing as the next section is on bronchiolitis, I think that this is a very highly recommended little video clip as well. So the nursing assessment of a child with croup is to note the child's age. Generally 3 months to 3 years, although it could be as high as 6 years of age for a child to present with LTB. The history may reveal a cough that developed overnight. That is the most common presentation. The cough sounds like a barking sea lion. Inspect for the presence of mild upper respiratory infection symptoms. Temperature may be normal or mildly elevated. Listen for inspiratory stridor, so that's upper airway, and observe for substernal retractions. Auscultate the lungs for adequacy of breath sounds, and the diagnosis is usually based on history and clinical presentation. The X-ray may reveal a steeple sign and is generally used to rule out epiglottitis, which is one form of croup. Nursing management is goal-oriented. The first goal is treatment at home, keeping the child quiet and discouraging crying, allowing the child to sit up, possibly in the parent's arms, encourage PO fluid intake. Recent studies show that a steamy shower is not helpful, so the best practice is not to do that. Administer corticosteroids by mouth if that's been ordered, and the parent should call the physician if the breathing is faster, they have retractions or difficulty breathing, if there's nostril flaring, lips or nails have a bluish tint, if there's cough or stridor that does not improve, that restlessness increases or the child is confused, or the child begins to drool or cannot swallow. Treatment, if the child is in the hospital, is nursing goal to keep the airway open, and to do that we keep the child calm, put them on an O2 saturation monitor at all times, and administer oxygen to keep O2 sat above 93% if it's been ordered. We also want to administer medications. Those medications are nebulized racemic epinephrine, corticosteroids, usually IV to begin with, and then switch to PO before discharge, and to keep the child well hydrated. And if they're not drinking, they may need IV fluids first and then be transferred to PO as they can take it. This is the end of this unit, and the next unit is bronchiolitis.